With the RAPTIR block, you get an identical distribution of anesthesia that the infraclavicular brachial plexus nerve block offers. This is an extensive block from the lateral shoulder all the way down through the elbow, forearm, wrist, and hand. The RAPTIR block allows for excellent pain control and the management of many common arm pathologies encountered in the emergency department. An example would be an elbow dislocation, as shown here in this X-ray. Another example would be pathology involving the wrist, such as the Colles fracture, which is shown here. The RAPTIR block could also be useful in the management of incision and drainage procedures, such as the one used to manage this arm abscess, as well as for the care of burn injuries. For the best visualization of the anatomy needed to perform this block with ultrasound, the patient is placed supine. A towel roll can be placed under the shoulder. A linear probe is placed perpendicular to the clavicle as shown here. The probe can be slid medial and lateral until the landmark of the axillary artery is seen in the short axis. In this still image, we can see all the landmarks needed to perform the RAPTIR block. Towards the head, we can see the bright border and shadowing of the clavicle. The axillary artery should be seen as a circular structure. It's outlined in red here. The medial, lateral, and posterior cords of brachial plexus in this area are outlined in yellow here. The axillary vein should be caudal to these structures. Deep to these structures, you may see the faint outline of the pleural line, and this is an important landmark to identify, and so that you don't violate the pleural space during the procedure. This is a scanning video showing the identification of these landmarks. Again, we see the clavicle identified here with shadowing towards the head. The axillary artery is this circular pulsating structure here, and we can see the cords of the brachial plexus. The axillary vein is here. Deep to these structures, you can see the faint shimmering of the pleural interface. Once all of this anatomy is identified, you can prepare to perform the block. The needle is inserted just superior to the clavicle and advanced underneath the clavicle. The probe is kept in position with the superior aspect of the probe over the clavicle. In this image, we see a line that is drawn from the probe to the axilla, and so the ultrasound probe should be parallel to this trajectory, and the needle should also be advanced parallel to this, and so the tip of the needle should be seen exiting from underneath the clavicle and easily visualized with the ultrasound. This animation shows the ideal trajectory of the needle. The target for your needle tip is just deep and cephalad to the axillary artery. As the needle approaches the neurovascular bundle, you should see the tip emerge here and advance to your target, which is shown in this orange star here. If the needle tip is placed in the correct position within the axillary sheath, injection of anechoic anesthetic should fill around all three cords. This is a still image of the RAPTIR block being performed. The needle is highlighted here in white with the needle tip here placed just deep to the axillary artery within the axillary sheath. A total of 25 to 35 mLs of anesthetic is required to achieve adequate block using this technique. There are important advantages and disadvantages to the RAPTIR technique to this block. This block can be compared to the infraclavicular or supraclavicular brachial plexus nerve block as described in a separate lecture. The advantages of the RAPTIR approach is that the needle is advanced parallel to the pleura, and so this offers a theoretical benefit that there is less chance of violation of the pleura with the needle. Patient is supine, and this is a comfortable patient position to perform the procedure. The anatomy is quite simple, meaning that the number of structures that you need to identify is small. This is similar to the brachial plexus blocks. Given that the needle is advanced directly underneath the ultrasound probe and parallel to the probe and perpendicular to the ultrasound beam, there is better visualization of the needle. The downsides to the RAPTIR approach is that there is about a 3 centimeter blind zone for which you are advancing the needle underneath the clavicle and are unable to visualize the needle during this time given the shadowing of the clavicle. Certain anatomic variants may make this block more difficult. One would be an abnormal clavicle, such as previous fracture that may distort anatomy. In patients with short necks or a thick pectoral area, the technical aspects of this block may be too difficult. Thank you very much for your attention and for your interest in performing nerve block procedures that can greatly benefit our patients.